Welcome to the Cataraqui Woods Dental Implant Institute, a nonprofit organization dedicated to furthering both education and research in the field of oral implantology. My name is Dr. Waji Khan. I'm a dental surgeon and also the CEO of this organization. So what's going to be brought to you today is by this new thing that I've started up called the Top Gun Dental Implant Study Club. For more information, visit the website at topgundisc.com. Basically, our mantra is become the best of the best through education, training, and mentorship. What we have for you today is a product review on the Nobel Active implant through our experience in our clinical use. So the agenda for today, or the outline today, is going to be basically a product introduction, specifications for this dental implant in terms of product, packaging, and reported features. Features, what's new, what's missing. Surgical and prosthetic tools and the ergonomics of these. Number 5, performance in terms of both price and quality. Number 6, any comparables for this dental implant. And lastly, number 7, case examples, and then summary and conclusions. So in terms of product introduction, the Nobel Active implant was actually not invented by Nobel Biocare, but was invented by a gentleman by the name of Dr. Ofer Fromovich, who spent many years developing this in Israel, and this implant patent was purchased by Nobel for their exclusive use. It was a very popular implant due to some of its unique reported features. It was very unlike the implants that had preceded it. So in terms of specifications, in terms of both product and packaging and reported features, the product itself is made in one of these Nobel Biocare state-of-the-art facilities. There's a number of unique features that when this implant first came out of the market brought to it increased primary stability and other sorts of features. But as you'll see, a lot of these features actually have been around for many, many years in other implants. So going through some of these features specifically, number 1, they have apical drilling blades to allow adjustment of implant angulation. So many times in cases where you're drilling into very dense palatal bone in the maxilla, you're able to come from a very buccal position and almost manually place the implant inside the bone and take it towards a more lingual or screw retained position. It also has, number 2, reverse cutting flutes for a gradual widening of the osteotomy. Number 3, what Nobel Biocare refers to as tie-unite surface, which is basically their sandblasted titanium surface. So you'll remember back with the Nobel Biocare MK2 implants back in the early 2000s, they went from a machine surface to a roughened surface. This had been known in many other implant designs for many years to increase bone-to-implant contact, but Nobel Biocare calls their surface tie-unite. It also has what they refer to as, number 4, the back-tapered coronal design for maximum alveolar bone and soft tissue support. Some people would also refer to this as a platform shift. Number 5, it has double lead threads for gradual bone condensing and high stability even in soft bone. If you want to actually check out what's really cool with this implant is it actually will cut from the apical perspective. If you ever go to one of the trade shows and someone can show you a sample of a Nobel Biocare Active implant, you can actually take it and screw it right into your finger and you can shake your hand around as much as you want. The thing is not coming out. Number 6, it has an internal hex conical connection, and number 7, platform shifting. So in terms of packaging, the packaging is pretty straightforward. It comes in these little round tubes, which for most people, they don't really care. But if you're carrying a lot of implants along with you, it actually makes it quite more easy to transport implants from even operatory to operatory, not necessarily from like office to office, in these little round tubes. It makes it really easy to sort of see the sizes on the top as well. Nobel Biocare has conveniently marked these off for you. As you snap open this little tube, what you see here is the picture on the right is another tube which can be placed into a sterile field really nicely. And inside here, if you go into the next slide here, you'll see that once you pop that top off, you can access your implant. And using either a hand driver or the handpiece driver, one can engage that implant. And as we talked about in the previous features aspect, you can go from the buccal aspect and move the implant towards a more labial screw retained position in maxillary applications. That's one of the cool things with this implant. In terms of other reported features, what's new, what's missing. So in terms of what's new, there's really other than perhaps the fact that you don't have to drill or prepare the bone as much, and you're relying more upon the cutting flutes of the implant to engage. There's not really much that's new. A lot of the features that are incorporated into this implant, like the micro threads, PROSTHETIC has had those along for I don't know thousands of years, but at least a couple of decades. The prepared surface that was first sort of introduced by the endopore implant back in the 1980s or 90s. The conical seal, or the conical connection, that's something really which PROSTHETIC has had around for many years. The internal hex is something which was first introduced by Zimmer with the tapered screw vent implant. The platform shift, well, that's kind of neat to be incorporating this into this implant. But other than that, in terms of the only thing that's really interesting about this implant compared to some of the other, in terms of comparables, is the fact that at the apical aspect, it actually will cut bone. So if it's the case that you have performed an osteotomy in soft bone, if you're not careful and you're placing this implant at the torque amount, like some people recommend placing this implant around 80 Newton centimeters torque, you can actually make the implant go a lot further than where you actually intended. And one of the consequences of this is you can actually end up taking it into anatomically sensitive areas. I had one colleague who, through misfortune, was able to actually even ding the inferior alveolar nerve, and that wasn't quite an experience. In terms of what's missing with this implant, well, it really comes down to some of the surgical kit features. The surgical kit is kind of bare bones basic when you purchase it. For $2,000 US, which is sort of the going rate for the introductory Nobel Active surgical kit, it actually doesn't even come with drills. You got to buy the drills separately. So it's kind of like, okay, well, hold on, didn't I just pay like a lot of money for a kit here? I was expecting at least get like an initial series of drills. So going to the next slide over here, which talks about once again just going over some of those features. You can sort of see how you can engage the bone and move it with the picture on the left using the hand driver, and just a product overview provided by Nobel Active or Nobel Biocare for the active implant. And this is another photograph here showing the bone condensing properties of this particular implant. So surgical and prosthetic tools, if you go to Nobel Biocare, they'll provide you with this Nobel Biocare branded OsseoSet 200. Basically, this is the standard implant med unit that pretty much every company has put their label on. There's nothing unique to it, though the foot pedal, they did try to modify it a bit to make it look like it's not like one of the others, but basically it works just like any of the other units. And this is the workhorse of my practice. I have about 3 or 4 of these with various brands on them, and they all work the same. They work well with the irrigation tubes and the hand pieces. We use the W&H hand pieces in my practice. In terms of the surgical kit, here's a top view, so you can sort of see here. It comes with the one hand wrench. It comes with the depth measuring tool on the left. There's a unigrip driver. There's 6 different drivers depending on whether you're using the 3.0, which is the narrow platform, the regular platform, the wide platform implant. There's a short and a long version of this. And on the right, basically just follow those you have the extension drill on the top right, but a lot of people what they end up doing is taking that extension and putting it where the spare compartment is and putting the actual precision drill up there. And then basically it's a matter of following the chart. We'll move down to the next picture here, which shows this a little bit better here. Just Nobel Biocare has a description for 1, 2 in terms of which platform implant and whether you're in soft bone, medium bone, or hard bone. The parentheses basically indicate that you're supposed to use that burr, but not go all the way to the apical depth, just sort of use it to basically drill the coronal bone away. There's a lot of spare compartments, which is kind of nice as well. If you want to keep like a Lindemann burr or any of those sorts of things in here, that's kind of nice as well. There's also 4 direction indicators if you're doing like sort of like the all-on-4 technique from a radiographic perspective. Go to the next slide. You can see one of the Nobel active impression copings. I love these impression copings. They're pretty awesome. And when I say they're awesome, it's nice because they're long, so they're easy. They're nice for those of you. I'm 6'2" with I use large gloves. So it's nice to not have to handle small components and try to make sure they're engaging inside. So the longer it is, it sort of makes it a little bit easier for those klutzes like myself that need large things in their hands. Not to say the small things we can't make it work, but anyway, this is nice to have. And also these nice big flanges here really grab onto impression material, so you're not going to be getting any sort of movement or distortion in your impression for when you're putting that implant analog on there, which basically translates to error, giving either tight contact or no contact or poor contour or poor emergence profile for your implant. Going to the next slide here, you can see once again that these impression copings can also be customized. In this case, the individual is using a little bit of GC pattern resin just to sort of get a more accurate impression of where the, in this case, they used a temporary abutment to sort of help form the papillae or the soft tissue bed in and around this implant. And here's a picture of the prosthetic kit. Once again, just like the surgical kit's kind of bare bones, the prosthetic kit is just as bare bones. Not that you need a lot of stuff, but if you compare this to some of the prosthetic kits you get from, say, Tech, which is, I'm going to say this in pretty much every product I've used, like, is my favorite prosthetic kit. I pretty much use it for 99% of my cases. It doesn't matter which implant system it is. I always have it beside me. I mean, it's kind of a bare bones kit for a prosthetic kit, and considering the price of it as well. So ergonomics. So basically, it's a standard implant med unit with a WH handpiece. Nothing special here. The kit flows nicely and logically, though it is kind of bare bones. It's very few parts that do come along with it, both the surgical and the prosthetic kits. There's really no color flow system. However, there's minimal preparation, which is required for most of the time when we're using the 3.5 millimeter implant. It's really like just 2 or 3 burrs and Bob's your uncle sort of thing. Very easy to use. So performance in terms of both price and quality. So it's a very premium implant. I mean, you're looking at around $450 Canadian, or around, I guess, what would that be, $350, $400 American. So it is a more premium implant. The implant doesn't come with the cover screw, so that costs you an extra $30, $40 for that. And basically, pretty much everything, as you can pretty much guess, from here on in terms of the burrs, the impression copings, the healing abutments, the UCLA abutments, everything is premium priced. And so if it's the case that you're trying to basically manage your costs for your patient and provide them with implant therapy at a reasonable cost, this is not an implant system, or at least using the name brand system. There are a lot of aftermarket components that are made for this implant. I can't really comment on them, but what's it called? If you're looking to provide, to low cost care, you can't really do that using this system. The prices of many of the items are at the upper echelon. In terms of quality, though, it is a high quality product. It's great packaging, and you do get excellent service. Nobel Biocare, at least in Canada anyways, has a wonderful online ordering system, which I really appreciate whenever you're trying to get a part and get it overnight and not have time to, or I guess not feel social enough to get on a phone and stay on hold and talk to someone who will send it to you. Just log in, order what you need, boom, 5 minutes later, you're guaranteed to have it the next day or two. So in terms of comparables, there's many comparables. Many of the features of the Nobel Active implant have been incorporated into other implant systems. So I'm not trying to say that people have ripped Nobel Active off, but many of the Nobel Active features were from previous implant systems. So they basically had taken a lot of these features and incorporated into this implant system as one. So I guess it's only fair that other people have sort of copied some of their incorporations as well. So let's take a look at a case example here. We'll look at patient A, which is a 62-year-old healthy male who basically presents with a failed post-core crown complex on the upper right lateral incisor, and he's seeking a fixed implant solution. So looking at the radiograph of this patient, you can see that this post-core crown complex has failed. There is adequate ferrule if you wanted to attempt placing another post inside this tooth with a core buildup and recrown prepping it. However, it would lead to a very poor crown to root ratio, as one can appreciate from this radiograph. We presented the option of a implant therapy to the patient, and the patient wanted to go with an implant. So the patient had adequate buccolingual bone, adequate height of bone, adequate interarch distance, adequate root form, all those sorts of things. So treatment planning basically consisted of consent photos, models, etc., atraumatic extraction of the tooth, immediate placement of the impalatal bone using the precision drill, and a buccal position leading towards a palatal position to get that screw retain position. In this case, we did decide to graft the gap or jump junction. There is some controversy in this regard. Some people don't believe in placing dead bone into these areas and basically start stating things that you're basically slowing down the body's own natural process of healing in this area. Allow about 4 to 6 months for healing, and then bring the patient back for a stage 2 surgery and deliver a crown and some sort of a bite plane and follow-up. Those who that know me know that pretty much I give every patient, any patient who I do any sort of expensive dentistry on, they all get a bite plate. So taking a look here, we can see we put that failed post-crown complex back in to position, and there it is out of position. And then we proceed with a atraumatic extraction for the patient. So there's the tooth out. You can see we tried to preserve the soft tissues for the patient. Keep in mind the buccal lingual position of the soft and hard tissues prior to extraction and implant placement. So there you can see we did used the precision drill to create some sort of a palatal hole, and then basically follow through with the final burr series there. Go and grab our Nobel active implant. In this case, you can see I'm using a hand driver to start off with buccally and then move that more palatally. As you'll see here, we finish this in a palatal screw retained position. If you just follow the line of the incisal edges there, you'll see that we will have a screw access hole that will be on the palatal, but one can appreciate that large buccal gap jump junction that does exist. So in this case, we decided to graft it. They say if it's greater than, say, 2 millimeters, you sort of have to graft it. So in this case, we took a mineralized cortical cancellous large particle, 250 to 1,000 micrometer allograft, and mixed that with some plasma from our PRF, plate-rich fibrin preparation, allowed that to hydrate for about 10 minutes or so. And once that's been hydrated, we basically place a cover screw onto the implant. And once that cover screw is in place, pack some bone graft inside there, grab some platelet-rich fibrin, and use some fancy suturing to hold that into place. Give the patient about 4 to 6 months to heal. This radiograph here is basically immediately post-op, so one can appreciate the placement of the implant. And in post-op checklist for this patient, make sure that there's a transitional prosthesis that's placed. I don't like doing bonded restorations for patients, so pretty much all of my patients will receive either an SX retainer or some sort of a flipper. Make sure that post-operative instructions are provided in terms of care of the surgical site, oral hygiene and rinses. Post-op medications are provided in the form of both analgesics and antibiotics. That post-op follow-up appointment is scheduled for the patient, and finally, that the patient is fit for discharge with a responsible adult escort. So in this picture here, you can see that we brought the patient back. We performed a stage 2 surgery and placed a healing abutment, all in the span of a few sentences there. One can appreciate that there was a little bit of buccal, soft and hard tissue resorption as a result of removal of that tooth. And in this picture here, you can see that we removed that cover screw. One can appreciate the nice, healthy, soft tissue around this Nobel active implant. And in this picture here, you can see that we've placed the final prosthesis for the patient. One can appreciate the unfavorable crown to root ratio, but nonetheless, you can see that the bony architecture and stuff has been preserved around here. And from an aesthetic perspective, you can see that this patient is happy. Actually, the patient has 2 implants, the lateral incisor and the contralateral central incisor. Those are probably the best 2 looking teeth in this patient's whole arch. So in terms of patient B, we'll go to the second case here, which is a 52-year-old healthy female who has a edentulous site posterior to the upper left cuspid, and she has a bruxism habit, and she's seeking a fixed implant solution. So in this picture here, you can see a photograph from the occlusal aspect of this patient's arch retracted, and here's a radiograph basically outlining the same thing. So this patient really wanted 3 implants, but we only went with the 2 in this particular case. So in treatment plan, basically consent photos, models, etc., a full thickness flap for the patient, placement of 2 dental implants, and allow 6 weeks for healing, and then perform a stage 2 surgery with progressive loading to basically let the bone heal, and then also, because she is a bruxer, to basically allow it to heal prior to putting a full size prosthesis on there, just in case she does start bruxing her teeth and stuff. It's not going to be detrimental to the implants. And then lastly, deliver the prosthesis and a biplane and follow-up for this patient as well. So here we start from the palate here. Palate aspect, full thickness flap, reflect this flap, and this is what you can see. Some nice bone for this patient. And then basically using our initial pilot drill, following the root form of the cuspid there, basically place the pilot drill in, take a radiograph to ensure that we're not going in the direction that we don't want to go in, and then basically subsequently using the direction of this pilot drill to make the osteotomy for the second implant. Now, you can appreciate from the subsequent radiographs that the second pilot drill or second implant was not going to be the same size. You also have to make sure that the implants are spaced far enough apart that you're not going to end up causing issues by having them too close together. And in this picture here, you can see that we use that osteotomy to place the first Nobel active implant using the hand driver in this particular case. And then once again, go ahead and place the second implant. Place these down to the bone level where we want them at the 80 Newton centimeter torque, which is recommended by the manufacturer to place these implants at. And you can see now we've got the cover screws on. In this particular case, we only had 2 Nobel active cover screws, and I dropped them on the floor. And the old expression always is, surprises in implant dentistry are never a good thing. So sadly, I didn't have another Nobel active cover screw. But however, this system was compatible with one of the Zimmer cover screws that I did have in stock. So we were able to basically take a sterile Zimmer cover screw and use that in this particular case. One will appreciate once the sutures have been placed in. We also placed platelet-rich fibrin in this case prior to placing the sutures. Taking a look at the radiograph, one can appreciate the conical nature of the cover screw for the anterior implant, and how the posterior implant is something that's sort of like just covering things there and make sure nothing gets inside. And you can also appreciate that we were getting close to the floor of the sinus in the matter of the second implant. So observing where the bone levels and stuff are. Going to the next slide, we see the Panorex, panoral radiograph for this particular patient. This is just a photograph of the different types of impression coping. So on the left is a Nobel active impression coping. On the right is a knockoff impression coping. As I'd mentioned, the length makes it a lot easier to place. And the second thing is you can see those beautiful flutes that stick out. They really grab that impression material, and you really feel very sturdy when you're inserting the implant analog into the impression coping, that things are not going to either rotate or move in any direction. So here's a photograph of some healing abutments that have been placed after the fixture level impression has been taken. Here's a radiograph of these healing abutments that are in place for the patient. And when the patient comes back with the prosthesis, you can see we take those healing abutments off, see how things are nicely healing around these implants with those conical seals around these implants. And in this particular patient's case, we gave the patient 2 premolars fused together in order to get more stability and also to sort of alleviate the bruxism habit that was reported. You will notice there is a bit of bone loss on the distal aspect of the anterior implant. My hypothesis was that probably the compression necrosis as a result of high insertion torque of the implant initially. In this photograph here, we have it was not a photograph. I guess we're talking about a summary here. So summary in terms of product introduction for the Nobel active implant, specifications in terms of product packaging and reported features, features in terms of what's new and what's missing. We talked about surgical and prosthetic tools and ergonomics, performance, price, and quality, comparables, case examples, and lastly, summary and conclusion. So what's the conclusion? What's the view on this implant? So it's an excellent product. It's basically a collaborative effort of many years upon years of innovations in implant design. It's a fairly easy implant to use. I wouldn't say it's for the beginner because of the fact that it does have the coronal aspect that will cut and things can go beyond the desired osteotomy. So, it's not probably an implant you want to start your career off with. You probably want to use something easier, like, something like a Zimmer tapered screw vent implant, which has a domed apex that it basically is limited in terms of where it can go. In terms of customer support, Nobel Biocare is second to none in terms of customer support. They have a vast network of representatives throughout the world, and their web support is excellent as well. And lastly, in terms of value, it's an expensive implant. It's a pricey implant. I basically refer to it to my patients as the Rolls Royce of implants. In terms of using this implant as compared to another implant, from a personal perspective, I've used Nobel Biocare implants on family members. I've used, more value-based implants on family members as well. It all comes down to sort of what people are willing to pay. In case you're wondering, I didn't charge my family, but I'm just saying I felt comfortable using either or on family members. With patients, they always ask me, is it worth paying the premium? I always just tell them, hey, it's like some people like driving a Lexus. Some people would rather just drive a Toyota. What type of person are you? And people make choices, and some people decide, I want to pay the premium. And some patients say, if you're comfortable with giving me the other implant, I'll go with it. So that's basically my spiel when it comes down to the Nobel active implant. A couple of references that we used in the production, not just this product review, but also the education series that we have for basic implant placement course. And on behalf of everyone at the Cataraqui Woods Dental Implant Institute, I want to thank you for listening to our presentation.